afternoon, everyone, and thank you for joining us today for our webinar from the University of Minnesota Center for Bioethics. We are incredibly pleased today to have Dr. Owen, who I will introduce soon. I'm going to go through just some quick logistics so we can give plenty of time for Dr. Owen to speak and for us to have a good conversation. So just some logistics, please use the Q&A function to ask questions and let the center staff know if you're having technical difficulties. We will be recording this, and attached is the link, which you will get in a presentation details document. We have enabled captioning for this webinar, so directions on how to utilize that. And there are 3 ways to access the evaluation. After the event, it'll pop up in the browser. It's also going to be in the presentations details document, and you will receive an email after the webinar. If you're looking for credit for this, complete the form that'll be in the presentations details document for CEUs. For University of Minnesota students who are seeking IPE credit, you will have a reflection form in the presentation details document. Biomedical engineering students, you will also get credit for attending this webinar, and the instructions are on the screen, and you have to have attended 75% of the webinar to receive credit. We would very much like to thank our co-sponsors for Dr. Owen's talk today: the Center for American Indian and Minority Health at the University of Minnesota Medical School, Center for Anti-Racism Research and Health Equity, the Med School, the College of Pharmacy, the Center for Global Health and Responsibility, the Program in Health Disparities Research, Schools of Dentistry, Nursing, and Public Health, the Rural Health Research Center, Community University Healthcare Center, and the Department of Family Medicine and Biobehavioral Health. So it is my absolute pleasure to introduce to you all Dr. Mary Owen. Dr. Owen is an associate professor and the associate dean of Native American Health at the University of Minnesota School of Medicine in Duluth. Dr. Owen also provides clinical care at the Center of American Indian Resources in Duluth. I could applaud Dr. Owen for the next hour, but I'm going to end doing her bio there because I really want to give her time to share her wonderful presentation with all of us. So I will turn it over to you, Dr. Owen. Thank you very much for joining us.
Thank you. Let's hope I can get this right here. All right, can you all see my screen?
Yes.
Slides? Excellent. Thank you. I want to thank the Center of Bioethics, and particularly Dr. Deb DeBruyn, for asking me to give this talk today. I think it's an important talk and something that's on my mind frequently as I take care of patients and teach about Native health. So you've already heard about who I am, so we'll pass that. I don't have anything to disclose, and I'm going to move right into this. I do want to make a couple of qualifiers. I'll go back a second. I want to make a couple of qualifiers that end-of-life care is not my world or my specialty because there are so few of us Native providers, however, and so few resources. We're often called upon for a myriad of health issues facing Native communities. And it isn't a stretch for me as a family doctor who practiced full spectrum care for over a decade and as someone who believes that everything is connected. That said, please forgive me if you work in this area and I'm missing something important. I did a quick lit review and tried to catch everything that I could, but I could be missing something important. I apologize. For this talk, I've compiled a list of publications and resources for caring for Native people at the end of life. 2 resources that I want to call out that were particularly insightful was the body of work done in this area by Dr. Judith Kitts and publication by Medicaid and Medicare that I'll reference in the talk. And I'll share these slides with the Center for Bioethics so that you can take a look at them on your own after my talk. I did forget to introduce myself because I ran over those first slides. I want to do so now. Udashu hat du asak ushkatana hat siti haitidach ayahat akwandach ayahat. I introduced myself in my own language, my Tlingit language. I'm from the Thunderbird House of the Shark Clan of the Algonquin tribe of the Tlingit people from Southeast Alaska. And apologies as well to anybody from my community for having probably murdered our language. Still learning. I know that many of you are hoping for concrete suggestions on how to engage Native patients, and I'll share a couple of ideas, but I'm hoping that I'm able to convey to you all today that the solution to this problem is the same as the solutions to Native health, education, and socioeconomic disparities. We need broad-based changes in all of these systems. Our healthcare disparities have existed since 1491. And until we make significant roads in addressing the socio-political inequities in this country, those disparities will change little. And finally, one last point I'd like to make before we dive in is that I am only one, or not only, but I am one Alaska Native from one of over 570 federally recognized tribes. As Indigenous people in this country, we have numerous belief systems, and within each tribe, there exists a wide range of beliefs and different degrees of cultural immersion and assimilation. We are not a monolithic people, and I can't tell you how Native people believe on any given topic. I can only tell you some relatively common values and beliefs amongst us and give you general guidance on how to get to what Native patients want, what we want at the ends of our lives. This talk's also not about any specific traditions or practices, though I will give you a couple of references to my own tribe or for what I learned from the Anishinaabe or from my students here from around the United States, Native students around the United States. These are the objectives. Examining the principles of clinical ethics from the perspective of American Indians, Alaska Natives, which we'll do quickly. And then I don't think any of you need to know that recognizing and applying clinical ethics to end of life begins long before those discussions with our patients. But I'll talk to you about why it's critically important for Native patients in particular. And then finally, identifying approaches discussing advanced care planning with Native people. I was approached in 2018 by Lynn Betzold of Honoring Choices in Minnesota to help increase Honoring Choices reach to Native American communities regionally. I was immediately interested because of my own experiences as a physician for my tribe in Juneau. One story that I remember well is that of a patient that I'll call Sam. Sam had end-stage COPD or emphysema, and he was hospitalized at least every 6 months. At each visit, respiratory therapy and nursing staff approached me to ask if my patient was sure that he wanted to be full code. I did so for the first 3 to 4 times, but then stopped asking. I could tell that Sam was getting frustrated with my asking him this question every time he was hospitalized. Sam was a man who loved life. It was clear if anybody who knew him knew this about him. And I was doing harm by advocating and frustrating him with my asking questions are the same questions over and over. I was doing harm to him and to Native people in general by not advocating more for us as providers and not for my patient. Staff was advocating for their own comfort. If they were truly serious or truly wanting to ensure his comfort, they and I would have listened to him the first couple of times. I was and continue to be interested in this project to ensure that Native people are given the autonomy to decide what happens at the end of their lives. But I don't think what happened with Sam was necessarily because of his race. I think, unfortunately, this happens too often in hospitals. What really bothered me, though, was that the trust was eroded with one of my Native patients. Trust is a valued commodity with any patient, but particularly with our Native patients or patients from underserved and underrepresented populations. You're looking on the screen right now at some pictures of my beautiful mom. And I want to share a story now that illustrates how clinical ethics can be applied differently and experienced differently by different patients, and very likely because of their race or socioeconomic class. In early 2023, I traveled to Petersburg, Alaska to take my mom from her home in an assisted living center to Juneau, Alaska to see a cardiologist for new onset heart failure symptoms. On waking in Juneau the morning of her appointment, it was clear that she was too sick to wait for the clinic to open. She was too short of breath to get around. We went straight to the emergency department as she was admitted and tuned up enough that morning to get her to the cardiology appointment with Dr. Park, or I'm sorry, her cardiologist down the hill. Dr. Park is her cardiologist from the Alaska Native Medical Center who travels out into the field for clinic appointments. Dr. Park recognized that she needed a new aortic valve emergently and made arrangements for her to be medevaced that evening to Anchorage. In Anchorage, we went to a non-native hospital that specialized in transvalvular aortic valve replacement surgeries, or TAVR. We met with the surgeon and were anxiously awaiting the procedure on the day of surgery, which happened to be February 14th, when we had a pre-procedure visit from the cardiothoracic surgeon who was to be standing by in case anything went wrong. He discouraged us from choosing to have the valve replacement surgery. Several times, he stated my mom's high risk and that he didn't think she should have the procedure. When I mentioned my concern that she would have no quality of life without a new aortic valve, he ignored me. Specifically, I stated that she couldn't walk without becoming short of breath and likely wouldn't tolerate typical heart failure medications such as beta blockers, given her low blood pressure. He realized this was true, and then he started to talk about the natural processes of aging and death, including his experiences with his own parents. He related all of this to quality of life, but he was confused by her diagnosis of dementia, stating at the end of his 10-minute lecture that she didn't seem like she had dementia, and asked if she was hard of hearing. Regarding his confusion about her diagnosis, he also didn't know that she had had cardiothoracic surgery at the same hospital. He was surprised when I mentioned it, and then even questioned it and asked to see her chest scars. He stated, after talking with us, he stated he'd be back to talk with us more after calculating her risk for the procedure once he had more data. But before he left, he asked my mom's race and looked doubtful when we said we were Tlingit. Only when I said she was also Filipino did he seem satisfied with our answer. He then told us about his experience with Filipino food from all of his Filipino nurses. So in addition to having to endure another episode of Guess My Race from a non-native, my mom and I had to listen to another condescending story about someone's brown-skinned nurses and their great food. My mom was also a Filipino nurse. Fortunately, the cardiovascular surgeon never returned, and instead the interventional cardiologist, arrived to tell us that they were going to go ahead as planned. He and his team arrived before the scheduled hour, wheeled their way in within 2 hours. He was back to tell me that the procedure was a success. Prior to this, my mom was a very mobile, though sometimes unsteady woman who would often, just for fun, sit backwards on her scooter and fly down the hall to her room where she lives with her husband of 60 years. She and my dad are so close that I'm sure he will pass within months of her eventual death. They both have dementia, but can still identify everyone around them. They have 3 children, my brothers and me, who visit from the lower 48 as often as possible and who still talk to them whenever we can reach them. They're often downstairs visiting with people. All communication is through our mom because our dad can no longer hear. Additionally, it's our mom who's always been the center of our family. She's tiny but mighty, and she loves life. My brothers and I sometimes laugh at her insistence on going everywhere at any time because of her fear of missing out on life. She will always choose life. I tell you these stories because they're reminders of why this work is so important, but also of what Native people continue to encounter in healthcare. As providers, we must consider how these experiences might impact their choices, our choices. Patients' experiences in a racialized and class system influence their choices about medical care, beginning with their choice of whether and when to engage healthcare systems. Ethical care presumes access to care. Discrimination decreases access to care. Perhaps you're thinking that my mom's story was just one story and not the norm. This is a graph from a study by Susan Pumala and colleagues published in 2016 using implicit association tests. They demonstrated a strong preference for white adult and pediatric patients by emergency room physicians at different hospitals in the Midwest. I debated whether or not I should include this slide because I know that there are questions about whether implicit association tests actually predict discriminatory behavior. But I decided to include it because I can't think of a single time in discussing emergency room experiences with Native people that they haven't related a story of discrimination either for themselves or a family or friend who is also Native. Of course, discrimination is not new and can be attributed to centuries-old narratives and acts meant to dehumanize Native Americans in order to take our precious resources. This is a picture of President Biden, who is delivering a long overdue apology for this government's role in creating boarding schools to assimilate Native people. In addition to boarding schools, Native people have endured removal, relocation, termination, allotment, sterilization, and the list goes on. Let's not forget that the US government has never adhered to its treaty responsibilities as promised to Native people in exchange for land. Despite a promise to provide healthcare indefinitely, our healthcare services remain severely underfunded, which of course impacts our health. And here's why this matters most. Discrimination impacts patient choices and their access to healthcare. In this graph from a study by Findling and colleagues, they demonstrate, you can see that Native patients are significantly more likely, by that first line there, to avoid seeking healthcare because of discrimination and interacting with police also because of discrimination. So again, lack of access to healthcare, which ends up being an ethical issue. Many Native patients also make healthcare choices based on their level of cultural belonging. This is a picture of my grandma Marie's second husband placing her vest on me during our potlatch party for her. It is our custom to hold a community-wide party about a year or so after our family's members have passed away. The primary purpose of this party is to thank members of the clan that held us up while we were grieving our loss. We also take care of clan business at the party, like adoptions. And here I'm being gifted my grandma's vest. My brother behind me in this picture has on one of our clan hats. Our regalia, or our atu, is a living spirit of our relatives. This is a very important belief for us. Thanks in large part to the work of the Interior of Holland, the purpose of boarding schools to assimilate natives by forcing them to forget their own culture and learn Western culture is now more commonly known. But for some government officials, it wasn't enough to teach Native children Western ways and to separate them from their parents and their culture. In 1883, the federal government, through the Office of Indian Affairs, implemented a code of Indian offenses that banned traditional Native American religious practices. These policies would remain in effect until at least 1934, when new Commissioner of Indian Affairs John Collier issued Circular Number 2970, which mandated that no interference with Indian religious life or ceremonial expression will hereafter be tolerated. The cultural liberty of Indians is in all respects to be considered equal to that of any non-Indian group. Despite this ruling, we know that that Native practices, Native traditional practices, were discouraged up until the 1970s. In 1978, in fact, when Congress passed and President Jimmy Carter signed the American Indian Religious Freedom Act. It recognized that government policy had inhibited the practice of Native American religions, including access to sacred sites and use of sacred objects and materials. This is critically important as our culture and our ways were taken underground in order to protect them, particularly religious ceremony. Now, this is a picture here on this slide of the ghost dance. I know that this is not. We know that this is not a long traditional practice. What is important, though, is that Native people. This dance developed in response to what was happening to Native people, and they were practicing it around the country, but particularly among the Lakota people. And while they were practicing it, Cheyenne River Group was practicing it, they were slaughtered for their practice of it. Again, this is one of the reasons that our traditions went underground. Boarding schools, the ban on traditional practices, relocation from tribal lands, and termination of tribes greatly impacted Native people, but still we survived. And we did so because of our culture. Enough tribal members had the foresight to keep traditions alive. And now we even have proof from the work of Indigenous researchers like Dr. Melissa Walls of the protective factor of culture. Involvement in culture can improve health outcomes. This is a picture of mine from a celebration following repatriation of our regalia. our Atu, as we call it, from the Peabody Museum in Massachusetts. And you can see the dancers there. They are their dancing is to bring our Atu back to life, bring our spirits, our relatives, the spirits of our relatives back with us. Again, our regalia is the representation of our family members who have passed and is very much alive. They're still with us. Regarding this cultural revival in throughout the country, this is a picture of a mural painted in the last 10 years on the side of the American Indian Community Housing Organization in Duluth, Minnesota. In the Northwest, where I'm from, our art is everywhere. This mural was the first very visible sign that Duluth is smack in the middle of Indian country. But it's just one sign that our culture and strength are growing. Cultural and language camps are far more common than just 20 years ago. Now, one last story to illustrate the importance of culture, particularly at the end of life. And I'm going to read directly from this fascinating, important paper that covers the history of events leading up to an amendment to the Minnesota autopsy statute that allowed for objections to autopsies based upon religious beliefs and practice. And again, all of this is included in the resources cited that you'll have access to after this talk. Mushkub Abid was a 65-year-old Native man who was under the care of a cardiologist for heart-related symptoms. He died in a single vehicle accident on Highway 210 in Carlton County, Minnesota. Witnesses said his vehicle slowly drifted across the center line, gradually going off the road until it hit a utility pole. First responders were unsuccessful in reviving Mr. Abid. Family was told that he did not appear to have sustained any obvious outwardly visible signs of serious injury, which led the family to conclude that he likely experienced a medical event while driving. Coincidentally, his father, who experienced similar heart-related symptoms at the same age, also passed away very suddenly at age 65. And at that time, his sons ensured that their father's Medea-Win beliefs were respected. The State Patrol did not request an autopsy because they did not believe Mushkub Abid's death was related to his automobile accident. However, the medical examiner for Carlton County insisted on an autopsy without speaking to the family, despite repeated requests by the widow to hospital staff or the police that she be allowed to speak with the medical examiner. Rather than attempting to speak with the family as they requested, the medical examiner staff appeared to avoid interactions or conversations with the family altogether. In an apparent effort to avoid having to speak with or have contact with the family, the medical examiner staff went so far as to initiate a 911 call Sunday morning, requesting the presence of law enforcement at the hospital as they prepared to transport the decedent to morgue space, which the medical examiner rented from the School of Medicine on the campus of the University of Minnesota Duluth. With police standing by, the decedent's body was taken from the examining room. While transporting the decedent, a nurse handed the widow a post-it note with the name and phone number of an unidentified person from a 507 area code. No further field investigator for the medical examiner. No further information was provided, although the family learned later in the day that this person was a field investigator for the medical examiner. If the medical examiner or his staff had attempted to speak with the family, they would have learned that the family objected to an autopsy because Mr. Abid was a fervent believer in the Medea-Win spirituality, the ancient religion of the Anishinaabe. Followers of the Medea-Win believe that any cuts or lacerations into a body after death is a desecration that can impede the person's journey into the spirit world. The family's beliefs also require that they, 1, wash the decedent's body in cedar water within 24 hours after the death, 2, feast and pray at sunset in close proximity to the body every evening until burial, and 3, keep a spirit fire burning near the body so the decedent's spirit can rejoin the family every evening for the feast. These beliefs also require the family to remain in close proximity to the body. The family followed the van transporting the decedent into St. Louis County to the loading dock of the medical school on the UMD campus where the morgue was located. The family was met by more law enforcement officers at UMD. In the midst of a snowstorm, the family would remain in the parking lot outside this loading dock for another 24 hours in order to practice their religious beliefs. At approximately noon on Sunday, February 8th, the family learned from third parties that an autopsy was to be performed on Mr. Abid at 3 p.m. that day. Tribal and family advocates spent the morning attempting to establish contact with the medical examiner. After contact was made, the family made multiple requests that the medical examiner at least allow them access to the body to perform the ceremonial washing of the body in cedar water. These requests were denied by the medical examiner. Later that afternoon, at the request of third parties, the medical examiner agreed to delay the autopsy until Tuesday. At 11 o'clock on Sunday night, counsel for the family obtained a court order requiring the body of Mushkub Abed to be released immediately to the family. The order was premised on the Minnesota Constitution, which had a strong statement regarding the free exercise of religion. In addition, case law has created a balancing test between the interests of the state versus the religious freedom acts of Minnesota citizens. After the signed ex parte court order was presented to the medical examiner staff represented by speakerphone, the staff representative refused to comply and would not release the body. Later, in a phone conversation with the medical examiner, he also refused to comply. The following morning, counsel met with the St. Louis County Attorney, which acted as a mediator, and called the Carleton County Attorney. Counsel for the family fully expected that the Carleton County Attorney would require the matter to go back to the judge on a motion to reconsider. Instead, the two county attorneys called the medical examiner and talked him into releasing the body. On Tuesday, February 10th, approximately 24 hours after Mr. Abed's body was released to his family, a similar incident tragically occurred near the Fond du Lac Reservation in Carleton County. 24-year-old Autumn Martineau of the Fond du Lac Band of Lake Superior Chippewa died in an automobile accident. Her family objected to an autopsy based on their Medeawan beliefs. The parties involved in Ms. Martineau's case were the same county attorney and medical examiner as Mr. Abed's case. Again, the medical examiner did not consult the family. As the medical examiner's assistants were taking the body, Ms. Martineau's grief-stricken family begged them to tell where they were taking her. Eventually, a police officer intervened and convinced the medical examiner's representatives that the family had a right to know where the body was being transported. Turns out that the body was transported to Hibbing, which is 70 miles away, despite the fact that the morgue facility in Duluth was much closer. In the midst of a snowstorm, the family was told by the medical examiner staff that they had 1 hour to get a court order to stop the autopsy, or it would begin as soon as the body reached Hibbing. Much like the Abed family, the Martineau family was devastated. A court order was obtained from Judge McCauley, who reiterated again that the religious freedom acts of the deceased and the right of the family to mourn in its traditional way outweighed the state's interest in conducting an autopsy. Yet again, the medical examiner was reluctant to follow the order. In response, the county attorney chose not to go back to the court on a reconsideration motion, but rather the county attorneys from St. Louis and Carleton counties again talked the medical examiner into turning the body over to the family, this time in a meeting at the Carleton County Courthouse on Wednesday, February 11th, that included Fond du Lac Chairwoman Karen Diver, in addition to the same counsel and advocates who worked on the Abed matter. In both incidents, law enforcement officers, county attorneys, and the medical examiner questioned whether the court order required them to return a body to a family. They argued that the Medeawan religion was not old enough, was not well known. In both those instances, the Carleton County medical examiner asserted that he had not encountered the Medeawan spirituality before, and specifically its prohibition on autopsies. I think now I'd like us to talk about or consider autonomy, beneficence, non-maleficence, and justice from a non-Western point of view. Native people tend to be more communal. Again, that's a generalization. Most tribal people believe in the interconnectedness of all living beings and the importance of maintaining the well-being of the entire community. So autonomy, for instance, though of course about individual rights, is also about what is right for the family and the community of the person deceased. In the case of Mr. Abed, the family was adhering to his personal religion, but his religion was one based on the importance of his community. The rituals and rites they performed were important to the welfare of all of those involved. Likewise, beneficence, non-maleficence, and justice are often not only about the deceased in Native communities. No presentation of mine is complete without a quote by Michael Marmot. And he reminds us that a lack of control over our lives or a lack of personal autonomy negatively impacts health. But this isn't just an individual problem. In the case I just cited, community members also had their rights, their autonomy denied. Community members witnessing being denied autonomy are also negatively impacted. So on to solutions and practices. Pardon me. First, I'll share what we did at the Center of American Indian Minority Health. Again, we're asked to help reach out to the Native American community locally and regionally to increase the numbers of Natives who are engaged in end-of-life decision-making with clinics and providers. I need to credit, here I want to credit Mangan Golden, who works in the center, she's our research manager, and she carried the load on this project and ensured that we completed it. She worked with students, community members, all involved. So thank you, Megan. We started with a literature search. We started our project with a literature search and found the following. When going over to, one of the biggest misconceptions that clinicians have is that Native patients don't want to talk about end of life care or end of life in general, and it is culturally taboo. This isn't necessarily the case. It just needs to be done in a respectful manner. So we'll talk more about that in a little bit. Death is just part of the cycle of life and not something to be feared. And that, again, this is a family, and the end of life decisions are family and community impacting. And most patients do want a relationship with their provider. After the lit search, we consulted with an Anishinaabe elder, an Anishinaabe medical social worker, and an Anishinaabe artist to modify the healthcare directive, which you can see on the screen here. We also reached out to a local lawyer who specialized in end-of-life decisions. Oops, just click something accidentally on my screen. Get rid of that. Sorry about that. Oh my goodness. There we go. Oh, okay. She helped us with the directive, ensuring our changes didn't violate any legal requirements. We also conducted a training with medical providers, and we developed a video for patients and providers and put it all into an end-of-life toolkit that's available on our website and at the end of this presentation. So we all know it's important to talk with patients early about end-of-life decisions. That's nothing new, but I put the slide in here to stress to you, after the things I said earlier, or the points I covered earlier, that this is even more necessary in communities that have significant mistrust of our healthcare systems. And building trust for conversations is about more than one-to-one conversations with patients. It's about institutional changes to convince communities that they truly are valued. In this article, it's one of the works of Dr. Kitts that I mentioned earlier. They talk about myths, just like we uncovered in our lit review. But I really like their list, and I wanted to cite it for show it to you. And remember, it's on the end of this discussion. Let me move you guys on my screen so I could see this and talk about it. Techniques that facilitate Native American end-of-life discussions. All patients and families should be asked on how they want to receive information, how they make decisions, and who needs to be present. I think that's obvious to all of us. I think it is important that all patients and families ask, even if they have family members who can translate. And again, most of us providers know this, that if they want a translator, and we should ask if they want a translator, but there are some communities that are still very adherent to or use their language quite a bit, i.e. the Navajo. Care provider often speaks in a third person. I think many of us know that we don't relate it directly to the person. Reassure that no harm is intended from the discussion. State that palliative care team and others provide hope for the best. Attention to appropriate hand and eye contact. I want to stress that not all Native people believe one way or the other. Tlinkits tend to be, my tribe, we tend to be very direct and make good eye contact. Make eye contact, it's not good or bad. Where some tribes, that's definitely not the way. Allow patient and family to control the tempo of the discussions, encourage comfort with silence, which I know is difficult sometimes for us as physicians. Schedule family meetings at the convenience of the family. I can't overstate this. Our families are often dealing with many different factors in their lives. Consultation with traditional healers, and lots of time for decision making. And one of the other things that we found out from our medical social worker was, if the first time it's a no, you just keep coming back. That people say that they don't want to discuss it, you just ask them later. It's an ongoing process. I keep having to move you guys on my screen over here. This is a slide, or this is a these are ideas that came from the Department of Health and Human Services, Centers for Medicare and Medicaid Services. And I know it's about hospice services, but I really want to emphasize there how this is a reference for people, even if you're not looking for hospices and just want to build better relationships with community. I think they got it right here. They included lots of different, some of the same work in their lit search that I cited earlier, particularly the work of Dr. Kitts. Gain support from tribal leadership, program staff, and community on palliative and end-of-life care. I cannot stress the importance of reaching out to anybody who's involved in the decisions that you're making. Create partnerships with national and local entities, and embed tribal consultation in programs to allow for more seamless cultural integration. Too often, we don't include tribes when on issues that impact them, and we're never going to get ahead unless we do. A culturally sensitive training curriculum for new and existing healthcare workers. I'll add in there that that should be longitudinal. Might seem like a 101 slide, but I'm surprised that it isn't as common sense as I think it should be. The number one, when you're communicating with Native patients, this is obviously just as important as what you ask. The first I put on there is body language, and I know that seems silly, but I want to remind people that as Native or in Western medicine, we're often trained to be confident, and many of us tend to want to walk into a room and just own the space. In fact, I'm going to mention the veterinarians here at the University of Minnesota a couple of times because I think they do great. They do great work, and this is one of the areas that they are very successful in my mind. They go out to tribal reservations and they hold clinics for animals and for pets and family members. And they are taught before going, all the students are taught before they go out to those tribal communities about body language, appropriate body language, language that conveys a little bit more humility than I think we're used to as healthcare providers. And I can't overstress how important that is. Ask to ask. Sometimes I encourage people to ask questions all the times of their patients or ask questions frequently of their patients about what their patients want and to get to know their patients. But I want to stress, I was told this by an elder not too long ago, that it's important to ask it when you can ask. Have polite curiosity, but do be curious. Remember, diversity of cultures and degrees of cultural immersion, assimilation. Many of us didn't get, our grandparents were raised in boarding schools, and talking about who we were was not encouraged. And so we're coming into our culture later in life. And it's an ongoing process. So you have to check in with your families or your patients and find out where they're at. Recognize and honor other cultural beliefs in clinics and hospital systems. I think this is really important, that you incorporate local and regional Native culture into the protocols and processes. For instance, some hospitals are doing this now where they allow for smudging. They allow for prayer and singing. In my own hospital in Juneau, Alaska, it was commonly recognized that if a patient with one of our community members was there, lots of community members were going to be there to see that patient. We, again, are very connected in our community. We need to compensate Native healers. Why do we not have Native people on staff just like we have chaplains? If you're truly valuing the community, then that would be a good sign of it. Additionally, something that I'm hoping will happen here in Duluth some point is to be able to compensate on-call traditional healers. Right now, we don't have enough traditional healers, so the program is difficult anyway. But if they're going to come in and take care of our patients and provide very important care to them, then they should be compensated the same way. And then tailor existing programs and documents, which I showed you an example of. I want to share with you one other important resource. Most of our tribal clinics, or in our IHS clinics as well, have teams of people that serve our patients. If you're going to discharge our patients to a rural area or to one of our clinics, rural or urban, it's helpful to reach out to our medical social workers or to the nursing staff at these clinics, and they can help ensure that the services that you're recommending are available for the patients, particularly for those of our patients who are in rural settings where that's not always the case. We have, or if you have any questions about services for our patients, if you are taking care of our patients at one of the private clinics or private hospital systems. And finally, I want to emphasize, I did get one question about rural, making sure that I emphasized how difficult all of this is, much more difficult all of this is when you are serving rural populations. And I put on a picture of Alaska just to show you how big our state is, and of the Leech Lake Reservation, which is more applicable here in Minnesota, obviously. Let me see if you can see my little arrow. So our clinic, or here it is, the clinic or the main clinic in IHS hospital is right here. But there are villages out here at Inger and Bina, Ball Club, and Onagum. And patients, and those are 45-minute drives. So our patients, they don't have many services out here in Inga or Ball Club or Bina or any of these Inger, any of these areas. And so most of the services are here. And that has to be recognized when we make recommendations for our patients, whether it's at the end of life or any time at all in their care. I got several questions, and I'm going to start addressing those now, and then I'll take more questions. It looks like there's some in the Q&A. I already called out the I didn't call out issues for folks with disabilities in rural areas. I did call out the rural, but disabilities, we just don't have the services available in rural communities. So it's important to touch base with our clinics and our providers to find out what can be possible. But yes, it's that much harder for folks with disabilities in rural areas. Do Alaska Native people generally subscribe to the same ethical values in end of life and other matters? I think we covered that. Native Americans care if their doctor is white or if the doctor treats them well. I'm not sure what this question is getting to, but I will state this, that I too have a great white doctor who I'm completely happy with. That's missing the point. When Native people, when we give talks and we say that we need more Native providers, what we're saying is that our children deserve to see themselves in these roles, that our community members deserve to see themselves in these roles. We all know about the power that comes with medical care and with the role of doctor, nurse practitioner, nursing. Why shouldn't our community members be in those same roles? Additionally, even though white doctors do incredible things, I have a doctor, again, doctors in this community that I work in that are always advocating for Native patients. They can't see the world the same way that we do. And it's important that we have that representation. Are you just jumping in there, Jennifer, because you want to ask me some questions, or do you want me to keep going through these?
I'm jumping in just to get ready to do some more Q&A. This is incredible, Dr. Owen.
Okay. Clinical ethics and mental health. I'm not quite sure where the person is, so if they're online and they want to clarify that, that would be helpful. How providers in different roles can be helpful, e.g. mental health providers, medical providers, hospice. I think we've talked about all those. It's the main way that people can be helpful is by helping us address the systemic issues that impact our communities. Would it be and help us get rid of the racism that continues to keep people from accessing the care that they need. End of life decision making for pediatric patients. I apologize, I don't have information on this. That would be a fantastic talk. I just don't have any more than I do for the talk here today. It's asking what your patients and their family members want and getting them the resources they need if it's different for pediatric patients. Major differences in beliefs among American Indian, Alaska Natives all around care, or the orientation beliefs similar. Again, over 574 federally recognized tribes. I cannot speak for them all, nor would I even try to. At the end, we all want dignity, right? We all want that autonomy, not just for ourselves, but in this case, for our communities. Is there anything that might be considered offensive to the patient when discussing end of life? You just have to talk to your patients and find out, ask them. If you go in there humbly, like we talked about, and then if you make a mistake, I have to do this all the time. I have a hoof and mouth disease. You make a mistake, you apologize, and you move forward. And I've never had that fail. Tips on getting a conversation started with older folks that grew up knowing the westernized way. That's a really good question. And I think that I hit upon it, that we have very varying degrees of assimilation. And some of my patients do not want to talk, are not at all involved in culture. And I find that out when I ask them about it. And then we go on. It's probably easier to have that conversation when you don't have to find out more about their beliefs. Let me see here. Organ donation. I'm not sure what they were getting at. Oh, I'm guessing that they're asking whether or not there's that myth again that we don't know Native people don't want to donate their organs. That is true for some natives, but I have organ donation on my driver's license, as do many Native people. So it's another question to ask. Personal need. Someone was wondering about memory care for a relative. Yeah, I think the best way is, like I said, to be asking the clinicians at the or in the caseworkers at the clinic where that patient is being served. Call them up if they don't know. They oftentimes will lead you to other resources and specific aids for speech language hearing in diagnosis of American Indian communities. Not sure that what they were getting, but I did sense that there was this misunderstanding that we might not have, or this misbelief that we might not have all those services. While we are significantly underfunded, we do have some terrific services in our clinics, and we have very much wraparound care. So for instance, at Fond du Lac here, we have in the same building, we have a chiropractor, we have PT, we have, well, out at our clinic in the south of us, about 20 minutes, we have eye, dental, um, we have counseling here and there. So we have a lot of wraparound services. Are they all that we would have if we were fully funded? No, but we do try to wrap everything around our community members as possible. And it's important we talked about this on Docs on Call last night. We were featuring Indigenous health. One of the key differences between tribal health and non-tribal health is that I think, having experienced both and worked in both, is that our services are definitely patient oriented, much more patient oriented. We get 20 minutes at the very least of time with our patients. And that was something that I didn't mention earlier, but I think that we could all do for our patients at End of Life Care is pushing back against these 10-minute appointments and demanding more for time with our patients. How do you develop those relationships without it? That's all I got here, Jennifer. You got some more for me?
I do. That was incredible, Dr. Owen. I can't thank you enough for what you've contributed for everyone here. I want to go back in the middle of your talk. You talked about culture as a protective factor.
Mhm.
And I'm wondering how we lean into that globally, not just with this community, but communities of all ethnicities, cultures, and how we make that more central in the context of using it as something to our advantage, as opposed to seeing it as something that makes things more difficult.
I love that question. That is so great. Yeah, I don't think that I dived in as much as I wanted to because I was constantly watching the clock. We have a traditional healer at Fond du Lac. We're privileged that way, and more tribal clinics are getting them. In hospitals, we know there are chaplains. When I talk to my patients and ask them about their beliefs, I even ask them, would you be willing to talk to a traditional healer? Are you interested in it? And I talk to them about the protective power of culture as long as they're not closed to it. I think that all of us, not necessarily even religious beliefs, right? But connections with one another. Are they connected in their community? If not to religion or to culture, then to other people in general. There's a great book out right now. My students are going to laugh that I bring this up because I bring it up to everybody lately. It's called Bowling Alone. And the person who wrote it, whose name I'm blanking on because I'm giving a talk right now, talks about the decrease in community and civic action and civil engagement, decrease in the number of knitting groups, church groups, farm groups, anything where we come together and share our issues. And we know that that's protective. That's what I hope that everybody is encouraging their patients to do, particularly in these not going to get political here. I'm just going to say we're in some tough times. So our patients need us to help them get there, I think, even if our patients like myself are introverts.
There were a couple of people that asked for some clarification when you spoke kind of about things to do to approach end of life in the community more sensitively, about speaking in the third person. There were just a couple people that questioned what you meant by that. And Also, if you could talk a little more about that body language issue, because I think most people recognize that body language says more than words, but what are people missing?
So I was in the easier one is the body language. I was in an emergency room with my husband maybe last year, and the doctor came in, who's I'm sure a fantastic doctor, but he, kind of swings the door open and he comes into the room and he sits down and he takes over the room, physically takes over the room, and commands the discussion. And I know that he was in a rush. I know exactly what this looks like, having done it myself. But he doesn't leave space for the patient to talk. He is just, what's the problem? Let's do this. And he's friendly and he's great, but he makes it clear that he is running that show. I think we need to slow down, to ask more, to walk more slowly into a room, to not be so. Um, I mean, you want to maintain your posture, but I think people know what I mean when I say that we take over the rooms. That's what I'm talking about with body language. On third space, oh, also, if your patient, here's another example. If your patient is not looking you in the eye, then maybe you shouldn't be looking them directly in the eye. That's a sign. Kind of mimic what they're doing. Regarding the third person, sometimes it's for some patients, it is more taboo to talk directly about death and about what's going to happen to them, and it can be more fearful, cause them more fear. So you could say that, if you could give an example of when someone comes in for when this happens to someone, might be the what's going to happen afterwards. As a result of this can happen to a patient. That's what I mean by third person. So you're not relating it to the patient right in front of you. And you're not saying, when you come in, we're worried this is gonna happen to you.
Great, that's helpful. Thank you. So speaking of the honoring choices documents, someone also asked if those go in the patient's medical record, how they're utilized, how patients are, advised to discuss them with their families, what you do with that.
I would give it I always try to make sure my patients have everything they need themselves personally, and remind them that their chart is their own. But it should be in the chart. A lot of people put those things at the very beginnings of the charts or on their medical record somewhere, so that it can be easily pulled up. I found when I was working in hospital, it's inevitably, even when we had electronic, somehow the document was missing and we'd have to ask the same questions over and over and over. So it's got to be somewhere that people see it immediately when a patient comes in. Did that answer the question fully, Jennifer? I'm sorry, one of my friends is already texting about this talk.
Yes, absolutely. Just a couple more questions. You had touched a little bit on the idea of mental health care, but a number of people have asked for kind of some suggestions about culturally informed psychiatric care, and whether there are resources available for that.
That's a really good question. I didn't come across that as a clinician myself. Um, it wasn't, yeah, it was not something that I had to deal with, and therefore didn't look up, and I didn't prepare that for this talk, and I apologize. I could do that and we could come back, but I don't
We'll
have anything specific.
ask.
I think most important again, though, is going to the community members and asking them. You get to know the community. It's always the same thing, and find people that you and not just ask one, but several people as you get to know the community. What are the ways? What are traditional ways? And then you have to still ask your patient or their family, in the case of the person being impacted so much they can't share it. You might ask the family members, what's important to you all? And do you know what's important to your loved one here in this case? But I don't have any specifics, and nor do I know of anything in the literature. And I will tell you that there is very little about us in general. It's one of the problems that we face.
Okay, well, this may be one that's out of left field, but a couple people asked it, so I just want to put it to you, Dr. Owen, and see what you think. But the question about medical aid in dying and perspectives of that, in the community, whether there is a generalized community perspective, which, obviously there is rarely one perspective from a large community. But if that's a conversation at all taking place in the community.
Not ones that I have been on, and I feel like I keep my ear to the ground with Native issues, and I've never heard that one discussed. It's hard for me to imagine. We have fought hard to be here for 500 years, and to survive 500 years. It's hard for me to imagine that we would be advocating for anything other than what my mom wants: life. We just want, if our life is coming to an end, we want it done with dignity and autonomy.
Well said. All right, I'm going to ask one more question because someone asked if you thought there was a need or if it was even feasible to embed clinical ethicists within clinics, Indian Health Services, whether you think that would be beneficial, what your perspective is on that.
Absolutely not, unless they are Native. We know we have 10,000 years of knowing how to care for ourselves. We were told they weren't the right ways, but we know now that they are what have kept us alive. We don't need anybody else to tell us how to take care of ourselves. That's what our traditional healers help us with.
Well, wonderful. I think I'm going to leave it at that because that's a really nice way to end. And Dr. Owen, again, I think everyone is a wiser and more informed person after this hour with you. And I do want to just let the audience know that another series that we do in the Center for Bioethics is called Unpacking Bedside Bioethics. And we're looking forward to a talk on December 3rd about engaging patients' hopes for miracles. And then we will have Dr. Keisha Ray presenting in February, and we'll post that title to our website when we get it relatively soon. But we very much appreciate, and more, there's courses available in the spring through the Center for Bioethics for anyone that's interested, and all this information is also available on the Center for Bioethics website. Thank you so much, Dr. Owen. Thank you to everyone who attended, and thank you for everyone who made this talk happen today.